Good morning, good afternoon, good evening, wherever you are in the world. Welcome to our annual activities from the D-Food International, the Healthy Steps Diabetic Food Awareness. Today, the Western Pacific region is privileged, and it's our honor to be the first one who kick off today. But let's start today with the message from our president, Professor Dr. Harikrishna K.R. Nair.
Thank you, Professor Gulapa. I think it's a pleasure to actually meet all of you all. Can we, play the message? A very good day to all my friends and family members of our great D4 International. It gives me great pleasure to actually welcome all of you to our World Diabetic Day celebration with our healthy steps. D4 International, a mission with a vision. This is the new board members for 2025 to 2027. I would first like to thank all our regional chairs, regional advisors, country representatives, and full members for supporting us on the Healthy Steps Diabetic Food Awareness Day on the 16th of November 2025. D4 International is a registered international non-profit association under Belgian law, and the mission is to actually help people as a global organization consisting of people working in the field of diabetic-related food care. All are dedicated to providing food care. These people are spread across 7 regions in the world. Basically, Africa, SACA, MENA, NAC, Europe, Southeast Asia, and Western Pacific region. Our board members, regional chairs, advisory and our country representatives as full members are in all these 7 regions, according to the International Diabetic Federation and World Bank classifications. We would like to promote the global profile of diabetic food prevention and care through awareness, guidance, education, research, and professional development, ending avoidable low-early amputations due to diabetes worldwide. We are actually the implementation arm of the IWGDF. Our goal is to prevent and reduce the number of unnecessary amputations from diabetes worldwide and improve the quality of their life. Training healthcare professionals how to manage diabetes-related food problems effectively and prevent amputations, giving healthcare professionals strategies to implement, develop, and sustain food services, and promoting the recognition of diabetic food specialists. So we want to close the gap of available and affordable diabetes food care. And World Diabetic Day is the culmination of our great work together. Our activities along the way includes train the food healthcare professionals step by step in each country, and our World Diabetic Day Awareness Week, which we're celebrating on the 16th of November. We have many partner organizations, if it includes the IDF, IWGDF, ISDF, Limb Preservation Alliance, the Royal College of Podiatry, the World Union of Woolly Societies, Diabetic Food UK, American Limb Preservation Society, the Canadian Podiatry Medical Association, Wounds Canada, International Associations of Diabetic Food Surgeons, DFSI of India, RK Diabetic Food and Podiatry Institute, Research Society for the Study of Diabetes in India, Interprofessional Wound Care Association, the International Committee of the Red Cross, International Université Numérique Francophone Mondiale. So we have many flagship programs, and the latest is actually Train the Food Trainer for healthcare professionals. And this is going to be carried out completely 2025-2027, and we would like to kick off this basically in all the 7 regions. This is something that is a key performance indicator for all the regional chairs in all the 7 areas. This is our Diabetic Awareness Week. We start at 8 CET with the Western Pacific region and proceed to Southeast Asia, Africa, MENA. Global meet will be from 14 to 15:30 CET. And then we have got Europe, NACA, and SACA. We also have the webinar series, which is Sherlock Saturday, 14 CET for 2025-2027. We've already had the first session basically with Prof. Abbas from Africa, and then looking at hardest wounds and the surgical approach is the next one by Dr. Salma, and then I will cover on innovative wound care strategies, followed by different specialities from different areas, from podiatry, from plastic surgery, from nutrition, and also in terms of prevention. We have many newsletters which are ongoing continuously from 2023, 2024, 2025, 2026, 2027. And then we have got our leaflets, basically, which are completely being disseminated everywhere by all of you. Thank you very much. You're doing a great job. The cost of treating diabetic foot ulcers in 7 regions, basically, research is very important. We look at the Global Wound Care Journal, which I have the pleasure of being the editor-in-chief. And we actually came out with a journey from the step-by-step diabetic foot program to train the foot healthcare professionals, 22 years of preventing amputation globally. This is actually with Abbas and myself. And this is something as a great publication that we are very happy to put forth to you. At the same time, the Aphrodite study and then the Asia Aphrodite study also, and our consensus document on the implementation strategies for the prevention and management of diabetes-related foot disease, which was updated, and we will actually update this in 2026 in Woes National. And our fourth Food International Conference, which will be held in Maldives from the 1st to 3rd of May. Thank you very much to Dr. Waheed, the Vice President, who is Chairman of the organizing committee for this. So what we have done is every year, basically, we are having conferences in different parts of the world to actually support and also push for the advancement of diabetic foot management in terms of prevention and also to prevent avoidable amputation. I thank God for all of you as my friends and family in supporting me as president for Food International and the whole board as a whole, together with our sponsors, Ergo Medical, Monleka, and then even Oneness Bio for these great sessions. And we would like to thank you for continuously supporting us all this while. And in 2026, the World Union of Relief Societies, where we are actually a supporting society, will have the session from September 23rd to 27th of 2026 in Kuala Lumpur Convention Center with the theme of Global Paradigm Shift, Wound Management, Specialty and Recognition. I thank you for a great this session, and I hope that all of you all will be able to share your expertise and clinical know-how and try to actually help all our patients who are actually our clients. So with that, thank you again, adieu, and have a wonderful World Diabetic Day. And let's work together for the betterment of diabetic foot management, prevention, and to prevent amputation, and most of all, save lives, save limbs. This is truly important. Thank you again. God bless you all.
Thank you very much, Dr. Harry. Now is the presentation from Western Pacific region. Today we have 3 distinguished speakers. The first one will be Dr. Luke, the Philippines. He has worked hard every day, try to save the limb of diabetic foot people. So he's a champion in our region. And as the theme of the World Diabetes Day today, they focus on diabetes and workplace. So today he will share with us in the topic of your feet, your future, preventing diabetic foot wounds in a busy work life.
Good morning, everyone. I am Dr. Luinio Tongson, Vice President of Diabetic Foot International from the Philippines. I want to start by thanking you for taking time out of your busy schedules. Today, we're going to talk about something that literally carries us through our workdays but often gets overlooked, our feet. For those of us managing diabetes, our feet deserve special attention. The strategies we're going to discuss are designed specifically for busy professionals like you. This isn't about adding more to your plate, but about smart, efficient habits that can protect your mobility and future. And why feet need special attention in diabetes. Consistently high blood sugar affects two critical systems. First, nerve damage. Imagine wear thick gloves on your hands all day. You're going to lose fine sensation. That's what neuropathy does to your feet. You might not feel a pebble in your shoe or a developing blister. Second, poor circulation means that when you do get a minor injury, your body struggles to deliver the healing resources it needs. Together, this creates a situation where small issues can rapidly become serious problems. Now let's talk about the perfect storm of busy work life. How many of you have ever thought, I'll deal with this later? When we're rushing between meetings, working long hours, and dealing with stress, foot care often falls to the bottom of your priority. But here's the catch. That's exactly when problem can start. Tight shoes during a long day, skipping foot checks because you're exhausted, stress raising your blood sugar. These are the moments when vigilance matter most. The good news is that with awareness and simple habits, we can avoid these traps. This is your most powerful defense, and it takes less time than checking your morning emails. The daily food checks should become as automatic as brushing your teeth. The ideal time is after your shower or before bed. First, do the soul search. Use a mirror if you can't easily see your soles. Second, actively look for changes, new red spots, blisters, cuts. Third, feel for warm areas with the back of your hand. Warm often signal inflammation starting. This 2-minute routine is your early warning system, catching problem when they are small and when they're still small and manageable. Let's get specific about what we're looking for. Pay special attention to high risk area between your toes, your heel, the balls of your feet. Look for any break in the skin. Even a tiny crack between toes can become problematic. Notice color changes. Unusual paleness or blueness suggests circulation issues. Feel for temperature variations. Localized warmth often means inflammation or early infection. Cold feet might indicate poor blood flow. And don't ignore dry, cracked skin. Think of these as potential doorways for infection. Being a good detective with your own feet is a skill that pays lifelong dividends. Your shoes are like a helmet for your feet. They're your first line of defense. Choose shoes with a deep toe box so your toes aren't cramped. Good arch support for all-day comfort, and a firm sole that protects you from uneven surfaces. Your socks matter too. Moisture-wicking fabrics keep feet dry and prevents friction. But here's the non-negotiable rule. Never walk barefoot. Not at home, not at the beach, not in the hotel rooms. That unseen piece of glass, that hot pavement, that stray thumbtacks, they all pose real risks. Indoor shoes or slipper are a must. Here's a practical tool for busy professional. Your foot care survival kit. Isn't complicated or expensive. A small bag with moisturizer for dry skin. Remember, apply everywhere except between toes where moisture can cause problems. Include a nail file for smoothing rough edges safely. And keep spare socks. If your feet get sweaty during the day, changing socks can prevent blisters. A hand mirror makes the sole search easy. And most importantly, antiseptic wipes and bandages for immediate first aid if you find a small problem. This kit is about being proactive rather than reactive in your foot health. Let's integrate foot care into your workday seamlessly. If you have a desk, keep a spare pair of comfortable shoes there. Changing shoes midday gives your feet a break and prevents pressure points. If you're a desk bound, set a reminder to do a simple exercise every hour. We're going to show you some in the next slide. If you keep your if your job keeps you on your feet, take every opportunity to sit and elevate your feet briefly. When traveling, don't break your routine. Your daily foot check is just as important in a hotel room. These small adjustments require minimal time but offer maximal protection of your feet. Practice these simple habits. Move and protect. For movement, set a timer to stand, stretch, and walk for 2 to 3 minutes every 60 to 90 minutes to improve circulation. Simple desk exercise help blood flow without disrupting work. For hygiene, wash feet daily with warm, not hot, water and mild soap. Avoid soaking feet for long period. Pat dry thoroughly, particularly between toes, and apply a thin layer of moisturizer to the tops and sole. Avoid applying lotion between the toes to prevent excess moisture. For nail care, trim nails straight across and file edges smoothly. If you have thick, ingrown, and fungal nails, see a podiatrist rather than attempting aggressive self-trimming. For managing minor wounds, for small cuts or blister, clean with mild soap and water. Apply an antiseptic and cover with a sterile dressing. Check the dressing daily and change it if becomes wet or dirty. Here's your desk exercise routine. Simple exercises that boost circulation without leaving your chair. First, ankle circles. Lift your feet and make circles in both directions. Second, point your toes like a ballerina, then pull them back toward your shin. Third, do heel raises while sitting. And for home, try picking up marbles with your toes. It strengthens foot muscles wonderfully. These exercises take just minutes, but they're like giving your circulation a coffee break. They prevent stiffness and keep blood flowing to those hard-working feet. This might be the most important slide. With diabetic foot care, wait and see is never the right approach. If you notice any of these warning signs, it's time to call your doctor. A small cut that isn't healing, persistent redness or warmth, any color changes, or unexplained pain, these are all signals from your body that something needs attention. Don't try to treat serious foot problems yourself with over-the-counter medication. Early professional intervention can prevent minor issues from becoming major complications. You are the expert of your own feet. Trust your observation. Let me show you visually why early action matters. Here in stage 1, we see a simple blister without normal sensation. You might not feel this. Without proper treatment, there is a risk of infection. Effective management might include cleaning the wound, relieving the pressure from the affected area, and applying appropriate dressing to prevent further deterioration and promote healing. In just a day or two, if not properly managed, it can progress to stage 2. The blister opens and becomes infected. Without proper care and good circulation, this can rapidly go to stage 3 or grade 3. Without proper and timely treatment, the ulcer might process to necrosis, where surrounding tissues start to die. This progression can happen in days, not weeks. But here's the hopeful part. Catching it at stage 1 during your daily food checks means simple intervention can stop this progression completely. Your daily check is your power to prevent serious problems. Many people feel anxious about calling their doctor. Here's a simple script to make it easier. Start by identifying yourself and the reason, like, "Hello, I am diabetic patient with a food concern." Then, report the facts clearly. "I have a blister on my heel that I noticed this morning. It's about the size of a pencil eraser, and the skin around it is red and warm." And finally, state your concern. "I'm worried because of my diabetes." This gives the medical staff exactly the information they need. Remember, they want to hear from you early. It makes their job easier and your outcome better. You are the most important member of your food care team, but you're not alone. Your healthcare providers are your partners. Make that yearly comprehensive food exam as a routine as your dental cleaning. During these visits, your doctor will check sensation with a simple filament and assess circulation, catching changes you might not notice. Come prepared with a question. No concern is too small. Many people benefit from working with both primary care doctor and a podiatrist. Remember, asking for help isn't a sign of weakness. It's a sign of taking control of your health. Let's recap your simple but powerful action plan. First, make the daily 2-minute foot check non-negotiable. Second, always choose protective footwear. Third, never walk barefoot anywhere. Fourth, call your doctor at the first sign of trouble. And fifth, partner with your healthcare team for regular checkup. These 5 habits form a complete strategy that protect your feet without overwhelming your busy schedule. They preserve your mobility, your independence, and your ability to stay active in the life you build. Thank you for your time and attention today. Remember, your feet carry you through your busy work days and enable you to enjoy life beyond work. They are truly worth every step of care and attention we have discussed. Thank you for your investing this time in your health and your future. Mabuhay!
Very much, Dr. Tongson. I like your talk very much. It's very, very practical. If you think about, only 2 minutes investing for your
Yeah.
feet that works for you all days, that's amazing. While I'm listening to your talk, I move do the, what did you say? Like exercise. I like
Just
that.
exercise.
Yeah, we all should do that throughout the whole session. We will keep the Q&A part at the end. So let's move on to the next speaker. We will talk about another side of the investment on diabetic food. Dr. Nicoletta Frescos from Australia. She's a podiatrist working at the La Trobe University. She will share with us about an economic viewpoint on diabetic food care.
Hello, my name is Dr. Nicoletta Frescos. I'm from Melbourne, Australia. My background is a podiatrist, and I'm also the Allied Health Research Lead at the Northern Health Hospital in the outskirts of Melbourne, Australia. I'm delighted to be part of this DFoot International World Diabetes Awareness Day and presenting to the Western Pacific region. So let's have a global look at diabetes foot disease. Diabetes is, as we know, highly prevalent with over 463 million people diagnosed with diabetes globally. Diabetes foot disease is a massive and growing problem globally. About 25%, that is 1 in 4 people, will develop a foot ulcer in their lifetime. And most of these ulcers will become infected, which can result in an amputation with up to 1 million amputations per year. Diabetes has become the leading cause of amputation, and we know that around the world, every 30 seconds, a lower limb amputation occurs due to diabetes related foot ulcers. But amputations are preventable with 85% that can be avoided if the correct line of treatment is provided. Now, DFU recurrence is also quite frequent. 40% of wounds will reoccur within 1 year and up to 65% within 3 years. Up to 70% of patients who undergo a diabetes related amputation will die within a 5 year period, which is higher than some of the quite common cancers. The financial burden of diabetes is estimated to be globally around 673 billion of the annual healthcare expenditure, although that figure seems to be quite different from different literature in different countries. And of that, diabetes foot ulcers account for about, in the US, 38 billion, and in the UK, up to about 1.3 million pounds. So the prevalence of diabetes mellitus will multiply rapidly with a more pronounced increase in the Western Pacific, Southeast Asia, Mediterranean, North African regions. And this is what's been predicted by the International Diabetes Foundation. The high costs for diabetes foot disease is reflected by the complexity and the diverse presentations of these diabetic foot ulcers. So, foot ulcers may heal within weeks, they could persist for months and years, or they could progress to amputation. This is due to the chronic and insidious nature of diabetes foot disease, which is complicated by peripheral arterial disease, and if in that case, and or infection, or it could be peripheral arterial disease, or it could be any other comorbidity that's related to diabetes mellitus. And often this necessitates prolonged and intensive treatment. Escalating the costs is both the demand for resources and the financial support required for patients and healthcare providers and the society. Healthcare costs for diabetes foot disease can either be direct costs or indirect costs. The direct healthcare costs may include long and repeated hospital stays and high bed occupancy, rehabilitation, medications, provision of wound dressings and offloading devices, diagnostic tests and imaging, and artificial limbs. Costs may also include consultations with various healthcare professionals, varying from vascular physicians through to podiatrists, nurses, etc. Surgical procedures, maybe revascularization, and amputations. Indirect costs can include loss of income or productivity, reduced quality of life, or caregiving burden. The indirect costs are very hard to get a sum and data on because there are so many indirect costs that we do not account for in our overall estimation of the cost for diabetes foot disease. The global financial burden of diabetes foot disease varies between countries, and also the collation of that information is quite outdated because we know that the prevalence of diabetes is increasing substantially. So here you can see a summary of what data I could find from various countries. The United States states that 33% of the annual cost of their healthcare expenditure is related to diabetes foot disease, 0.9% for the United Kingdom. Canada states that its annual cost per patient in international dollars in 2000, that's quite a while ago, was 22,000 or 23,000 international dollars, and it goes on. So it's really difficult to get a good figure across the globe as to what the actual diabetes cost is. When it comes to the Western Pacific region, it was even harder to get a summary of what the actual burden is. The latest study that I was able to find was conducted in Malaysia by Dr. Harikrishna, and that was published into 2022, and it compared the hospital admission rates between public and private. It compared the minor amputation, major amputation, and then the overall cost per patient per year that was calculated through a Markov model was identified to be in the public system 5,901 Malaysian dollars, which is equivalent to 2,193 Australian. And the reason I'm using the Australian dollars is to try and get some a better idea of the cost between the three countries. Australia, the last burden study that or economic study that I could find was conducted in 2015, and overall the cost of diabetes foot disease was 348 million in the public hospital system. Minor amputations and major amputations varied, of course, but they were much higher than what the cost in Malaysia. The other Western Pacific region country that I could find a study on was conducted in 2015, and it was based on 214 patients, and the total healthcare cost in regards to diabetes was $1.05 million, and 50% of these were related to amputations. A study published this year looked at the estimated cost of treating two standardized diabetic foot ulcers of different severity. It was a global study of the 7 regions with a total of 51 centres, and data was collected over a fixed period of time. So, with wound 1, the average estimated cost across the 7 regions was around $2,942, and for wound number 2, it was $17,403. The average time needed to cover that estimated cost for treating wound 1 was equivalent to 8.6 months of salary, and for wound 2, 22.7 months of salary. The authors used the purchasing power parity to be able to directly compare costs across the different countries. So this cost is sort of likened to the Big Mac index. When it came to the Western Pacific, for wound 1, the mean cost was around 3,200, and for wound 2, 18,000. So this is probably one of the only studies that has been able to do a comparison of similar data for particular types of wounds. A stepped approach for health costings in Australia was conducted in 2022 around the same time as Dr. Hari Krishna's study, which is fairly similar. I'm pleased to say that our study has been accepted for publication. This was announced yesterday. So we did a step approach doing a scoping review, qualitative interviews with key opinion leaders, collated that with the systematic review results, and then we put all that data together to undertake a health economic evaluation. There were some common themes. There were differences in treatment algorithms throughout the different regions of Australia and different professions. There were different resources and services used, and we also highlighted that the referral pathways also varied, but were more likely to start to follow the Diabetes Feet Australia guidelines. So, in summary, what we did was put it into what's called a Markov model, which estimates the average cost per year to treat a diabetic foot patient. And it goes through the 7 health states in weekly cycles over a period of a year. So we collected the data on closed wound, active wound, open wound post amputation, and closed wound post amputation. And all the variables are listed there, ranging from hospital admissions, inpatient, outpatient, healthcare practitioners, utilization, medication, wound dressing devices, and other costs. In a nutshell, the overall cost per patient per annum for Australia is around $20,600. The largest cost was from outpatient community care, which attributed to 44%, followed by wound debridement, 25%, and then hospital admissions. So what this calculation or economic evaluation provided with for us was a 5-year prediction of the burden for diabetes foot disease in Australia. So in 2022, the cost was 839 million. It is predicted in the 5-year period that the cost will increase based on the population increase and the increasing prevalence of diabetes mellitus. It will be around $1.2 million for the management of diabetes foot disease if we do not properly address this problem. So, in conclusion, there is a wide disparity globally for the cost of treatment of diabetes foot disease. But if we focus on the Western Pacific region, number one, we do not have enough data, but also the disparity is due to the different types of economies. Some countries within the Western Pacific region are classified as high income, whereas others are middle or low income economies. And given the complexity and multifaceted nature of diabetes foot disease, along with the variability in the management practice across the healthcare settings and across the regions, data may not fully capture all aspects of resource utilizations. In particular, for low income countries, the figures are highly underestimated due to the poor data collection and due to the high proportion of undiagnosed diabetes. So, future research should expand economic evaluations of diabetes foot disease to capture indirect costs and also patient related outcomes and the long term financial impact. These elements are essential for building a more comprehensive understanding of the true economic burden of diabetes foot disease. Integrating real world data will significantly improve the relevance and robustness of any future cost economic evaluation and cost effectiveness analysis. What we should be doing is developing national or international registries to collect this type of data. And using these databases could enhance the accuracy of resource utilisation estimates and also support evaluations of interventions in the real world settings. These are my references, and I thank you for the honour of presenting on this special day.
Thank you, Dr. Frescos, for your review. You can see that in our region, in the Western Pacific region, diabetic foot care is a big problem and it costs a lot and it's a real financial burden. I believe that it's the same everywhere in the world. So that's why we need to join together and share all this experience and work maybe harder to help to save limb and save life and also save the economic pocket for our patients. Okay, the Q&A session will be at the end. So we will move to the next speaker. The big thing that everybody who works in this field aim for is the happiness of our patients. So the next speaker, our president, he will share with us about the diabetes and health-related quality of life. Please, Dr. Hari.
A very good day to everyone. It's a pleasure from the Western Pacific region for me to present on diabetes and health-related quality of life. Now, if you know, basically, this is a great celebration looking at the World Diabetes Day. And this year, World Diabetes Day basically looks at diabetes and well-being, basically. This is the hospital I'm from, Kuala Lumpur Hospital, which is the largest hospital in Malaysia. We have about 2,400 over beds and about close to 12,000 staff. Now, World Diabetes Day basically was celebrated on the 14th of November 2025. We decided basically that, this is a flagship program of DFO International, and it has to be done every year. So this year, on the 16th of November, we have 7 regions basically celebrating World Diabetes Day continuously the whole day from 8 CET until the evening in Central European time. Now, as I mentioned earlier, World Diabetes Day 2025 talks about diabetes and well-being, and DFO International, being the implementation arm of the International Working Group for Diabetic Food, is very involved in the World Diabetes Day and is our flagship program. Healthy Steps for Diabetic Food in Diabetic Food Awareness 2025. That is what DFood is actually preaching, and this is our Diabetic Food Awareness Week. Basically, many countries are actually celebrating it as a global act against amputation. Now, what the main mission of DFO International is to actually prevent avoidable amputations. That is very, very important. So how many of you have got these kind of legs? Clear, beautiful, moist, basically. And in patients who have diabetes, basically, with diabetic peripheral neuropathy, with autonomic neuropathy, they have got, they don't actually have much hair, it's dry, basically, and then there's fissures, and then in diabetic sensory neuropathy, you find these insensate feet, and then with motor neuropathy, there are also deformities and all that. Now, diabetes is a global emergency. The World Bank divides the whole region of Earth basically to 7 regions, and we are in the Western Pacific region. And one of the things that we find basically is 5% of all diabetic patients have history of foot ulceration, and more than 25% have a cumulative incidence of this foot ulceration along their lifetime. If you look at the global achievement in terms of target for HbA1c, we find even in Malaysia, basically, only 22% actually conform to it, who actually get HbA1c below 6.5. Other countries, the same concept also. So when you talk about the concept of well-being, you talk about healthy steps, you also need to get targeted glycemic control. If not, basically, the complications will be astounding. In 1998, David Armstrong mentioned that basically diabetic foot complications can be prevented by up to 85%. Yes. And this is by basically proper assessment and also looking at your proper glycemic control and all that. So therefore, we need to control all this, examine your feet, make sure what you call this, the footwear is very important. With that, basically, for the Western Pacific region, we came out with the diabetic foot ulcer care in the Asia Pacific region. And this was actually a consensus document under Woes National, and we actually published it at that time. And there were many consultants and specialists here, including what they call this, 2 presidents from DFO International, and also from the different countries, basically Singapore, Taiwan, Vietnam, Thailand, India, Sri Lanka, and so on and so forth. The International Wound Infection Institute also came out with a document this year on therapeutic wound and skin cleansing. That means when you look at diabetic foot, we're always thinking about the aspect of management. That means cleansing, debridement, refashioning the edge, and also dressing with, let's say, biofilm-based wound care. We call it as wound hygiene now. But in therapeutic wound and skin cleansing, we go into cleansing itself, what needs to be done. And then we have got the IWI wound infection continuum, where they actually look at contamination, colonization, local infection, spreading infection, and systemic infection. So these are the covert and overt signs of local infection. And you can see basically, we're all looking at the management and treatment. But one of the most important aspect here is the prevention and later on the follow-up. So the use of antiseptics in practice was also what we call this another consensus document, all right, basically as more of case studies and research was done. So the burden of non-healing DFUs affects millions globally. The pressure on healthcare systems due to high costs, projected rise due to aging population and comorbid conditions, especially now with geriatric population, there's a huge increase, and also reduces the quality of life significantly. Now that is what basically I would look at, because when the quality of life comes down and you live longer, is it actually worth it in that sense? Because a lot of them basically physically also have problems, mentally also has problems, and the budgets of the country are insufficient to actually manage them. So we look at the impact of quality of life. Non-healing wounds drastically reduce patients' quality of life by limiting ability to perform activities, causing discomfort, social isolation, all that. So they get depressed. Impact on age. There is complex non-healing wounds may affect both young and older people, often linked to diabetes and all that. In this case, we're going to talk about diabetes and diabetic foot ulcers. The economic and daily practice impact is another aspect where you need significant resources translated into high healthcare costs and dedicated time for care. This is Maldives, basically. Nice, beautiful, all that. But you need to go when you're actually healthy. So one of the things about diabetes basically is in well-being, you also need to make sure you look after yourself well, and you should be able to relax and go to places like Maldives, which look so beautiful. And our fourth D-Foot International Conference will be held in Maldives next year. Now, if you look at the pillars of well-being, since talking about well-being, looks at physical, family, looking at environmental, financial, mental, and also looking at the career. So they should be able to perform, they should be able to fit into all these pillars. If you look at the health-related quality of life, it is actually a multi-dimensional assessment of a person's health, encompassing the impact of physical, psychological, and social well-being on their ability to live a fulfilling life. It is a patient-centric measure. So we talk about patient-centric care, we talk about looking at the whole patient and not the hole in the patient. All this is important. And this reflects how health affects the individual's functioning, feelings, and overall perception of life, and is distinct from general quality of life by focusing only on health-related factors. So we need to look at that. And health-related quality of life is something that we looked at basically even in the UK, about in 2010, basically, lots of studies on it, all that. And so now we have come back for diabetes and well-being. And the key aspects of health quality of life, physical health, number one. This includes patients' energy levels, pain or discomfort, and also the ability to perform daily activities like mobility and self-care. This is very important. Everyone wants to stay young, wants to be able to do things by themselves. Psychosocial health covers the emotional well-being, mental state, the absence of conditions like anxiety or depression. Patients who have diabetes are actually quite depressed. They have to take medication continuously. Those who are taking insulin, basically basal bolus regime 4 times a day, that are quite depressed with their condition. And then a lot of food that they can't eat, and they have to control their food. They have to exercise. They have to do a lot of things to control their glycemic levels. So this has a profound effect on the mental state and the biological effects and all that. And that's not counting also all the complications and side effects. Social functioning this actually affects their social relationships and interactions with others. That means how you interact with others, how you feel about yourself, and you're able to actually interact with these people. So this patient-centric perspective, where health-related quality of life measures health outcomes from the patient's point of view, not just from clinical or professional standpoint, because the patient is your client and he's the center of your system. Now, if you look tools like the HRQoL 5 dimensions, where they look at questionnaires of, EQ5D measures health quality of life across 5 dimensions: mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. So you have dimensions of well-being. People look at intellectual, physical, social, spiritual is another aspect, vocational, emotional, and environmental factors. And then you got quality of life in other sense, where it looks at a lot of health related quality of life, material aspects, quality of spiritual, psychological effects, quality of working life, quality of life in the family. Now, why working life? Basically, because nowadays they are extending the time for retirement. And diabetes is also affecting the patients much, much earlier. So in a quality of life survey, which was actually designed in the NHS UK, they looked at mobility. Are they able to walk, jog, exercise, friends and relationships, and how's the overall health? And what are the symptoms that they're having now? In the same time, basically looking at everyday tasks and all that, are they able to perform basically all these tasks at home? And the anxiety and stress levels. Now, these affect patients. And patients with diabetes have a lot of stress involved because with medications, with control, and a lot of things that they can't do normally. That means you talk about food care, footwear, and all these things. So they can end up basically with depression, anxiety, and all that. So we have to be quite happy and be quite careful with them. So it's important to actually look after them well. Now, the World Union of Wounding Societies, where DFO International is also a supporting society, has also come out with consensus documents and all that, looking at different types of aspects, and one of it is wound balance. Now, in wound balance, they actually looked at the implementation of this wound balance, where integrating all these clinical factors, biomarkers, wound assessment, all that, into the patient needs and effective communication, and to support a more comprehensive patient-centric care. So if you look at this, it's a proactive care concept with a holistic patient-centric approach, balances clinical care, wound care, and patient care dimensions, and the focus shift from wound management to wound healing, and supported by the global wound care experts applicable across various clinical settings and wound types. Now, if you look at wound care, we look at like basically biomarkers, oxygenation, trauma, comorbidities, critical for wound assessment. That's when we look at diabetic foot ulcers, we look at all these things. Now, we move a bit further when we look at this year's aspect, where we're looking at patient-centric care, focuses on the quality of life, effective communication, personalized treatment goals for patients. And you need to balance this in clinical care, where balancing clinical practice involves continuity of care, realistic time management, and early intervention strategies. So, why is this essential? Address the molecular systemic factors, support early intervention, provides structured decision-making support for clinicians at any level. So when you look at biomarkers, MMPs, macrophages, the receptors 1 and 2, elastase, calprotectin, growth factors, a lot of things. And you look at these impacts. So this is basically where you're looking at the patient, all right, at the wound itself, the diabetic foot ulcer. And then you move basically to provide early intervention. And this is where you prevent wound-related complications, you align therapeutic intervention, and support the shift to normal wound healing progress and optimal recovery. So always ask the patients about their health-related quality of life. What do they want to achieve? What do they want to do? What is their aim in life at that stage of life? And many people use timers, biomes, times, triangular wound assessment. People use triple dressings, super absorbent dressings. But here I would like to stress on patient education and individualized care. So you should educate the patients in what their needs are. Because many years ago, we did a study and we found that unmet needs is another problem that patients actually have, where they come in to ask questions, this and that, and then, find that we are so busy basically managing the patient's wounds or diabetic foot ulcers that we don't actually look at the patient holistically. And so we need to create personalized care plans to enhance healing and patient engagement. A clinical integration of wound balance is very important into all our clinical workflows. So the key benefits are basically what you call is you actually manage them well, wide applicability, and look at the implementation strategies and continuous improvement before we can actually go to places like this. So there's a lot of things they can do as near normal as possible. So we shouldn't basically limit patients with diabetes. And that's why this year, diabetes and well-being, we're trying to look at the health-related quality of life, trying to look at the patient as a human being and able to perform most of these things. So the 12 key steps to diabetic foot health, you're talking about basically looking at the foot. So basically, with proper stockings, comfortable stockings, so that the do's and don'ts are very important. And then we have got the foot care guide, how to look after your feet. People talk about washing the feet. People look about moisturizing the feet and also cleansing the feet, drying the feet. All this is important. And healthy feet, happy life. That's important. So inspect your feet, wash and dry your feet, and moisturize the feet. So this is the fourth conference which will be held in Maldives. The first was in Malaysia, second in Mumbai, India, third back in Borneo, and fourth will be from the 1st to 2nd of May 2026 in Maldives. Similarly, basically, we are having the World Union meeting in 2026 with the theme of Global Paradigm Shift, Wound Management Specialty Recognition from the 23rd to 27th of September 2026 in Kuala Lumpur Convention Center in Malaysia. I would like to invite all of you all to actually attend this particular conference. And DFood International has got basically a very good symposium and sessions even in this. And the whole board will be there. So it's a pleasure to actually have all of you over. And with that, let's take care of our patients well, holistically and comprehensively. And with that, I'm signing out from DFood International. Thank you very much.
Thank you very much, Professor Harry. Is there any? I don't see any questions from the participants. Okay. Today we move from very easy practical action that we can do every day, right? The 2 minutes investment to look at your feet every day and the 5 minutes desk exercise. Yeah. Okay. Yeah. And I think that's the most important part, because if we just do those things like 7-10 minutes a day, that can prevent your patient from developing diabetic foot ulcer, because you can hear from the talk by Dr. Frescos that diabetic foot costs a lot. It's a big burden on economic problem everywhere. And all of this, we want our patients to have a good quality of life. We need to take care of them in holistic care. Then all of us, including our patients, can enjoy the place like Maldives, right? Okay. We have a few minutes left. So may Dr. Abbas have any comment, please?
Yeah, the message went through very well. I really enjoyed all three talks. Your feet, your future was prevention, economic cost, and quality of life. Fantastic. Congratulations. Very good start. Thing. And even the distance, I mean, all regions, different distance, food, medicines. So that's an open resource to be tapped for the research. Yeah, and it'll be very good.
Yes. I totally agree. I think it's a very difficult one to put a money, dollar sign to it, because it's not just, as we both have mentioned, but also there's the cost to get to the hospital appointments, the cost of the carers, the cost of other side things that happen within the family because of the diabetic foot wound, the carers' time. You can't put dollar signs to the carers' time. How do you measure that? So it's a difficult one, and it's just as significant. It is just as important as the actual direct costs, because we don't take into consideration the carers, the family, which I would love to know how to do that. So if we could get, I don't know, somehow, I don't know how that would work. We need a good health economist to try and work that one out for us.
Yeah, so it's open. Yeah, carry on.
If you have good health economics also, it'll be very difficult, because the thing is, like what I was talking to Abbas just about before this meeting, that basically looking at cultural differences in different areas and all that, the types of transportation that they use, whether it's actually taxis, Grab, Uber, their own cars, buses, so everything is very in a very gray area, very subjective. That's why even when we did the burden trial, we were like, not too sure, because sometimes somebody is just nearby. They might just walk, or they take a bicycle and come over. But the wear and tear of the bicycle or the wear and tear of the car, all that is not taken into account. And car also same thing. Are you driving a normal Suzuki or are you driving a Merc? The price is also different. So how do we standardize all this? Because there's so many variables there, basically. See, so
my it's just an example, a similar example, but different cost entirely. With the Solomon Islands, because there's tiny little islands, there's only the one hospital. So to come to an appointment at the diabetic foot clinic, they would leave the day before and get on a little boat from the island to come to the hospital, and from the pier they would walk to get to the hospital. Then they would have, they couldn't get the boat until the next day, so then they would be sleeping outside. Like, it's just difficult.
Interesting. After Solomon, the other one is actually the Maldives. I went down to their hospital at that time also. You'll be surprised. So many islands. So they come to the Indira Gandhi Memorial Hospital, which is the main one in Malé. And, but they're slightly a bit more better in the sense they don't let you sleep outside. They let you sleep inside for 6 months. You end up a patient being admitted to the ward for up to 6 months. I mean, in my place, basically, we're looking at average length of stay. We want anyone to the medical ward 3 to 4 days. Anything more, we start doing a full, root cause analysis and find out what's happening, who is not doing their work or whatever, or some kind of stopgap method and all that. But over there, at first, before when they started actually advanced wound care, it was up to about 6 months. Poison dressings and all these things. So because they cannot go back and come back. Difficult.
Yeah, very.
Yeah.
Yeah, that's a good discussion because it shows that there are a lot of things that we need to concern, right? And is different from place to place. So we need like a real champion, like local people, try to implement the practical point to your work, to your daily life, and most of all for our patients, right? Okay. Yeah, please.
And Dr. But your study that you did over the 6th region, I mean, that just highlights the differences between regions and what access to resources they have. I think one country had $79 for the cost of a patient, but that's probably because they don't have any resources. What do they have in comparison to other countries? Yeah, so it's really inequitable, if I could say use that term, and it's a hard one, but we strive to try and do our best for people with diabetes foot disease, and the aim is to try and save those limbs, which is because saving those limbs will improve the quality of life.
I think one of the main things is basically in low and middle income countries, that the thing is how to achieve as near normal for standard of practice. We always talk about standard of practice, the SOPs and everything else, but if you don't have the particular resources, what can you do? The only thing you can do is, good work basically. I think all of you all are doing a great job basically. And I think we have got a lot of work to do in many of the low income countries. We should never end basically. And they are doing a lot of job and a lot of good things that they're working very hard. And I remember I presented a slide yesterday to the postgraduates where we showed them basically, in 1998, 99, we used to treat patients for a whole year just to close one diabetic foot ulcer. But now, within 40 to 50% of them, within the 4 weeks, we cut it down by 50% in terms of size and all that. And they all close within 12 weeks in a good center itself. So just picture other countries still going through that. And even maybe not only other countries, the regions in the outskirts and everything else. Same problem, basically. So we have to, I think, soldier on, basically. I think it's a continuous battle for years.
Yeah, no choice. Yeah.
Okay. Okay. There is one question. Oh, no. Dr. Shakawe said that perfect. Thank you to all of us. Thank you to you for following our session today as well. Okay, I think it's time, right? So thank you very much for the Food International, all the board members and all the speakers today, and also all the participants who joined us today. Hopefully, you learned something from our region and its benefits back to your work and enjoy your everyday work everywhere. The next session will be from Southeast Asia. So please join them to learn more from them. Thank you very much.
Thank you. Thank you very much.
Thank you. Great session.
Greetings from India. I am Dr. Milind Ruke, Regional Chair of Southeast Asia of Foot International, and I welcome everybody globally for this World Diabetic Day celebration awareness lecture series that we are having today. So this is the session of Southeast Asia, and you all know that World Diabetes Day is observed annually on November 14th, and it is an international day dedicated to raising awareness about diabetes, its prevention and its management. And the theme for this event this year is going to be diabetes across life stages, and prevention is the important thing that has been emphasized. And to start the program, I would invite our beloved President of D-Foot International, Dr. Harikrishna Nair from Malaysia, to open this program and say a few words and address the global community. Sir, welcome, and please come.
Thank you very much, Dr. Millen. First thing is thank you very much for your support and all that. It's the second session after the Western Pacific region for Southeast Asia, and we have got altogether 8 sessions up to next morning. I think Zaima can play my message. Thank you. A very good day to all my friends and family members of our great D-Foot International. It gives me great pleasure to actually welcome all of you to our World Diabetic Day celebration with our healthy steps. D-Foot International, a mission with a vision. This is the new board members for 2025 to 2027. I would first like to thank all our regional chairs, regional advisors, country representatives, and full members for supporting us on the Healthy Steps Diabetic Food Awareness Day on the 16th of November 2025. D-Foot International is a registered international non-profit association under Belgian law, and the mission is to actually help people as a global organization consisting of people working in the field of diabetic-related food care. All are dedicated to providing food care. These people are spread across 7 regions in the world. Basically, Africa, SACA, MENA, NAC, Europe, Southeast Asia, and Western Pacific region. Our board members, regional chairs, advisory and our country representatives as full members are in all these 7 regions according to the International Diabetic Federation and World Bank classifications. We would like to promote the global profile of diabetic food prevention and care through awareness, guidance, education, research, and professional development, ending avoidable low-early amputations due to diabetes worldwide. We are actually the implementation arm of the IWGDF. Our goal is to prevent and reduce the number of unnecessary amputations from diabetes worldwide and improve the quality of their life. Training healthcare professionals how to manage diabetes-related food problems effectively and prevent amputations, giving healthcare professionals strategies to implement, develop, and sustain food services, and promoting the recognition of diabetic food specialists. So we want to close the gap of available and affordable diabetes food care. And World Diabetic Day is the culmination of our great work together. Our activities along the way includes train the food healthcare professionals step by step in each country, and our World Diabetic Day Awareness Week, which we're celebrating on the 16th of November. We have many partner organizations, if it includes the IDF, IWGDF, ISDF, Limb Preservation Alliance, the Royal College of Podiatry, the World Union of Woolly Societies, Diabetic Food UK, American Limb Preservation Society, the Canadian Podiatry Medical Association, Wounds Canada, International Associations of Diabetic Food Surgeons, DFSI of India, RK Diabetic Food and Podiatry Institute, Research Society for the Study of Diabetes in India, Interprofessional Wound Care Association, the International Committee of the Red Cross, International Université Numérique Francophone Mondiale. So we have many flagship programs, and the latest is actually Train the Food Trainer for healthcare professionals. And this is going to be carried out completely 2025-2027, and we would like to kick off this basically in all the 7 regions. This is something that is a key performance indicator for all the regional chairs in all the 7 areas. This is our Diabetic Awareness Week. We start at 8 CET with the Western Pacific region and proceed to Southeast Asia, Africa, MENA. Global meet will be from 14 to 15:30 CET. And then we have got Europe, NACA, and SACA. We also have the webinar series, which is Sherlock Saturday, 14 CET from 2025-2027. We've already had the first session, basically, with Prof. Abbas from Africa, and then looking at hardest wounds and the surgical approach is the next one by Dr. Salma, and then I will cover on innovative wound care strategies, followed by different specialities from different areas, from podiatry, from plastic surgery, from nutrition, and also in terms of prevention. We have many newsletters which are ongoing continuously from 2023, 2024, 2025, 2026, 2027. And then we have got our leaflets, basically, which are completely being disseminated everywhere by all of you. Thank you very much. You're doing a great job. The cost of treating diabetic foot ulcers in 7 regions, basically, research is very important. We look at the Global Wound Care Journal, which I have the pleasure of being the editor-in-chief. And we actually came out with a journey from the step-by-step diabetic foot program to train the foot healthcare professionals, 22 years of preventing amputation globally. This is actually with Abbas and myself. And this is something as a great publication that we are very happy to put forth to you. At the same time, the Afro-Dial study and then the Asia Afro-Dial study also, and our consensus document on the implementation strategies for the prevention and management of diabetes-related foot disease, which was updated, and we will actually update this in 2026 in Woes National. And our 4th Foot International Conference, which will be held in Maldives from the 1st to 3rd of May. Thank you very much to Dr. Waheed, the Vice President, who is Chairman of the organizing committee for this. So what we have done is every year, basically, we are having conferences in different parts of the world to actually support and also push for the advancement of diabetic foot management in terms of prevention and also to prevent avoidable amputation. I thank God for all of you as my friends and family in supporting me as president for Foot International and the whole board as a whole, together with our sponsors, Ergo Medical, Monleka, and then even Oneness Bio for these great sessions. And we would like to thank you for continuously supporting us all this while. And in 2026, the World Union of Wound Societies, where we are actually a supporting society, will have the session from September 23rd to 27th of 2026 in Kuala Lumpur Convention Center with the theme of Global Paradigm Shift, Wound Management, Specialty and Recognition. I thank you for a great this session, and I hope that all of you all will be able to share your expertise and clinical know-how and try to actually help all our patients who are actually our clients. So with that, thank you again, adieu, and have a wonderful World Diabetic Day. And let's work together for the betterment of diabetic foot management, prevention, and to prevent amputation, and most of all, save lives, save limbs. This is truly important. Thank you again. God bless you all.
So, thank you, sir, for your very crisp and good message for the global community. We will definitely do everything that we can to support and be a part of this great initiative. So, in India, I did a very good program for World Diabetic Day in Khan Bahadur Kurla Baba Hospital, where I am the head of the department, and we did it in private also. There are a lot of programs done at Diabetic Foot Society of India members as well as RSSDI. So now it takes back me to the St. Vincent's Declaration in 1989, which was supported by WHO and IDF, and where there the basic thing was diabetes as a public health concern, recognizing it, improving education and awareness, access to care and prevention strategies. So on that basis, I think we are also moving forward, and I'm really happy to be part of the community in treating and preventing diabetic foot. So I think we will start the first lecture, which is on elective surgery in preventing diabetic foot. I think we have a video recording, we can play that. Good morning, all of you. Good morning to the President and the dignitaries. I take this opportunity to thank Foot International for giving me an opportunity to talk on such an important topic of diabetic foot and how elective surgical management of diabetic foot can prevent amputation prevention. As a surgeon, I am doing a lot of these procedures in India. My training in US has helped me in learning these techniques which I am implementing in India. India being the diabetic capital as well as low and medium income group country, I believe that because of very high cost of footwears as well as inadequate coverage by the insurance companies in these countries, surgical offloading as an elective surgical management of diabetic foot will definitely help us in amputation prevention. We have seen that lot of things have been sent in and talked about prevention of diabetic foot amputations. There have been recommendations in different articles that governments have to revise health policies. There should be introduction of new education curriculum. There should be allocation of health budget for non-communicable diseases, implementation of patient awareness strategies, enforcement of catch them young policies in medical colleges. I, with the help of Dr. Nair, Dr. Abbas, Dr. Vijay, initiated this program which we had declared in Madrid, Spain, in India, in spreading awareness and education in various medical colleges in India through online programs as well as physical programs, and establishment of diabetic foot clinics. This will all help in prevention of diabetic foot. But if government policymakers or organizations merely make promises without implementing changes, what can physicians and surgeons like you and me do for diabetic foot patients who return year after year with trust? How should we respond when they develop foot disease? Prevention remains the most effective approach, and this has been also included in the International Working Group of Diabetic Foot Guidelines as well as the Indian Guidelines ICMR 2015. It has been concluded that multidisciplinary approach and prevention are going to be very important for the future in the management of diabetic foot, a complication which is increasing enormously in the patients of diabetes. So, can a surgeon like me be a part of preventive management of diabetic foot? Certainly, if the multidisciplinary team aims to identify deformities, correct them, detect areas of high foot pressure, and perform surgical interventions to reduce pressure and prevent ulcer recurrence in accordance with IWGDF Guidelines 2023. The International Working Group in Diabetic Foot Guidelines 2023 have given clear and simple recommendations for preventive strategies. One of them is to detect higher risk diabetic foot patients if they have got abundant callus, ingrowing toenails, and fungal infection to treat them as preventive mechanisms. Patients having non-rigid hammer toes, mallet toes, you should also use surgical tenotomies, flexor tenotomies, Achilles tendon lengthening or gastroc release if the conservative treatment is failing, and if you have a demonstrable high risk foot with high pressure in the forefoot. Patients whose wounds are not healing with conservative management and footwear, patients where the ulcer is recurring, you can use this Achilles tendon lengthening and gastroc release surgical offloading methods to treat. Even metatarsal head ulcers, which are on the plantar and which are not healing, we can do metatarsal head excision. They have also said that don't use a nerve compression procedures for high risk foot and patient who have high risk foot and ulcer not healing and having painful neuropathy to give standard of care rather than doing nerve decompression. The surgical intervention for chronic deformities and ulcerations is an important component in management of diabetic patients as a preventive strategy, and thanks that it has been included in the DFoot International guidelines of 2023 if the conservative treatment fails. The outcome of these interventions are fairly predictable when patients are properly selected and evaluated, especially the blood supply. We have also included this as a special recommendation in ICMR Indian guidelines of 2015, which will be now renewed. The classification of diabetic foot surgery, as we all know, classified by Dr. David Armstrong and Frickberg, are 4 classes: elective, prophylactic, curative, and emergent. So, we are going to talk today about the elective and prophylactic management. In India, a decade ago, corrective surgeries were not done in a very high quantity or volumes, but now people who have been trained in US are doing these surgeries, and we have started also imparting training to Indian surgeons. We get foot like this foot with atrophy on dorsal forefoot, development of hammer toes. We have foot which are having cavus appearance, developing high plantar pressures under prominent metatarsal head and contributing to hammer toe, mallet toe. A patient with great toe amputation can develop deformities also, with which can be corrected with different procedures, as I mentioned, of flexor tenotomy, tendoachilles lengthening, as well as gastroc lengthening. So we have certain deformities like hammer toe, claw toe, mallet toe, which are known to increase pressure associated with neuropathic ulceration. Now, if these deformities are not rigid, they are flexible deformities or soft tissue, then you have to do correcting structural deformity surgery with resection arthroplasty, percutaneous flexor tenotomy, and which will augment healing and reduce risk of ulcer recurrence. So we have certain evidence of limited ankle joint mobility we come across when we examine the foot clinically, and we see that the Achilles tendon or gastrocnemius soleus complex is tight. We do silver cords test to find out where is the tightness, and accordingly we do release as surgeons the tendoachilles or gastroc release. We also do hammer to correction by resection arthroplasty. We correct the deformities like bunion and claw feet. This is a very simple procedure of tendo-Achilles lengthening, which we do percutaneously now, not an open procedure, and it has to be learned and carried out. Gastroc release, also a simple procedure that we follow. There is evidence, but in 1996 as well as more recently in 2024 by Mueller, these are some of the studies which show that doing resectional arthroplasties or doing percutaneous Achilles tendon lengthening and even supplementing the percutaneous lengthening with total contact cast decreases the recurrence and helps in decreasing the foot pressure, thereby preventing ulcer reformation. This was Mueller's study which showed a decreased recurrence from 81% to 38%. It was done in 2003-2004. Gastrocnemius recession is a simple procedure. Medial part of the leg, we take an incision and there we release the gastrocnemius, and you can find the ulcer healing with the help of footwear and this procedure. Flexor tenotomy is a very simple procedure. We can also perform by taking a 18 gauge needle, and you find the toes which are curved become normal and prevent a ulcer because of friction on the footwear. This is a small video which will demonstrate
కాళ్ళ ఈ కాలు
how
procedure
is done.
టైట్గా మడవండి
So this
టైట్గా ఓకే సో యాజ్ ఎ పేషెంట్ టు మేక్ ఎ టైట్ ఫిస్ట్ ఫ్లెక్స్
where
see
18
I have released
needle
tendons
to
two
release
tendons
the tendon,
you can
and you can see
feel I can feel the
this tendon
given away feel so the tendon tight kar only by doing a sweeping motion you can release the tendon
see the motion,
the contracted tendon
transverse
see, I am
motion
doing
to
this
cut the
another 26 another
that is how
16
it
see
got
this is
corrected. So
this is
this
okay
simple
Hell
procedure
madon
is can be done. Then arthroplasties, you can do K.R.'s arthroplasty. that has been demonstrated, and this Keller's arthroplasty, where the proximal part of the proximal phalanx is removed, so the windlass mechanism which is causing a loss of windlass mechanism which is causing the recurrence of great toe ulcer is corrected, and we don't get ulcers. This is out of box thinking. Hind foot ulcers which cannot be surgically offloaded, you can use a rotation flap technique where you can excise the ulcer and then have a rotation flap where, like plantar's skin, which is a specialized skin, the like tissue is replaced by like tissue, where this flap is folded and it is sutured, and you get. This is a video of the rotation flap technique that was done, and it showed that after the flap was closed, the like tissue was replaced by like tissue. This was done in 1996, and this is how we got a very good skin after doing this surgery. And the same patient on the other leg had a deformity where we did a fillet flap on the toes, and the toes were all removed and the flap was closed, and we did a tendoachilles lengthening. though this patient was not recommended to dance or do something, but he was so excited that he was doing this performance during his daughter's marriage. So this is how it helped him for the next 12 years. He had no regret. Metatarsal osteotomy is also a good procedure which neuropathic ulcerations under metatarsal heads, which is a challenging problem to heal. So we do metatarsal head resection mostly from the dorsal side, but sometimes we have to do it from the plantar side if there is a active ulcer. We use simple instruments like bone cutter, hemostat to do this resection. We can give this patient a window TCC and it can cause healing and reduction of time to heal as well as recurrence. So different metatarsal head papers have been submitted. Armstrong and his colleagues reported more rapid healing and lower recurrence rate in surgical group as compared with non-surgical care. These are some of the cases that has been come in the literature where the metatarsal head was removed and the patient was given offloading. Pan-metatarsal head resection is also been done in patients with multiple ulcers where you can prevent ulceration in the future. The good news is in India we have now trained surgeons in Southeast Asia. We have started doing preventive surgeries, healing ulcer by arthroplasty and TA lengthening, correcting deformities for accommodation in footwear and decreasing pressure, decrease foot pressure by surgical offloading. Elective is a upcoming technology or technique which should be implemented in preventing diabetic foot complications and healing and recurrence. Charcot foot, which we all know is a continued stress of weight bearing leading to more fractures, dislocations and deformity, and in later stages we always recommend surgical corrections as in especially in our climate where total contact cast the tolerability is less, the compliance is less. So wherever possible, we do surgeries like simple plantar exostectomy with or without tendon-Achilles release, midfoot realignment orthodesis, hindfoot orthodesis, ankle orthodesis, combination procedures most often required as Charcot deformities usually are multi-level. So we have this simple procedures of doing a simple exostectomy for a midfoot ulcer with prolapse of the bone. We also do a technique which is famous where a circular external fixation is placed after talectomy and fusion of the ankle foot is done by external fixator, a circular called Ilizarov technique. We also do simple bumpectomy surgeries, giving the shape and the arch back to the patient. And nowadays we have different new techniques which have come, a Masquet's procedure, then tibial transfer techniques, which definitely should be included in the armamentarium of the surgeon. The conclusion is the surgery on ulcerated or deformed foot has assumed an increasingly important role in the management of diabetic foot. Diabetic foot patients with peripheral neuropathy or ischemia at a higher risk for complications than non-diabetics. It can be used. Careful patient selection and thorough foot evaluation are cornerstones of achieving success. Surgical intervention on deformed foot can obviate many months of unsuccessful conservative care, and antibiotic stewardship should also be practiced in today's diabetic foot management. To end, early detection and protection of high pressure areas in the foot and corrective footwear, orthotics, and now elective surgery is the only strategy which I see to prevent loss of limb in diabetic foot. We in India, we have now started, along with Diabetic Foot Society of India, a Podiatric Surgical Society of India, which is recognized by the American Podiatric and International Podiatric Group. And we are thankful to Dr. Bal, Dr. Sanjay Vedya, Dr. Sanjay Sharma, Dr. Rajesh, myself, who are now trying to propagate podiatry in India in a big way, including diabetic foot management. So these efforts with a multidisciplinary approach, physicians, surgeons, orthotics, will go in a long way in preventing amputations in diabetic foot. We should remember that the St. Vincent's Declaration of 1989, we have still not achieved 50% reduction in the diabetic foot amputations. But all this together, the understanding of biomechanics, the preventive strategies would definitely help us in this achieving this goal. Thank you. Thank you, and please take care. Save the foot. I can take some questions if there are any. Thank you very much. So I think the next speaker from India is Dr. Manoj Chawla, and he is a very famous diabetologist in Mumbai, director and consultant diabetologist in Lina Diabetes Care. He is a diabetologist in PD Hinduja and SL Raheja Fortis Hospital, and he is a honorary visiting faculty in D.Y. Patil University. He was a scientific chair as well as organizing secretary of Diabetes India in 2023-2022, and he is a task force member of RSSDI. He has 40 papers to his credit in national and international journals. I think we can play his video now.
Hello everyone, I'm Dr. Manoj Chawla, consulting diabetologist, Mumbai, India, and I thank the D-Foot International, the Southeast Asian region, for inviting me to speak today. Dr. Vijay Vishwanathan, Dr. Milind Ruke, Dr. Amit Naghate, and other colleagues, thank you for having me here. So let me start by sharing the slides for today's presentation. Right, I believe my slides are seen. Management of painful diabetic neuropathy. So diabetic neuropathy encompasses a group of clinical or subclinical manifestations involving a dysfunction in the peripheral nervous system. Neuropathic pain is defined as non-physiological pain due to damage in the nervous system. It can occur in response to a given stimulus, independently of that stimulus or even spontaneously. The pain sensations are usually firing, burning, throbbing in nature, sometimes even described as different words by our patients. The prevalence of neuropathic pain is believed to be 7 to 8% in the general population, and would rise in the future. According to a study conducted in patients with type 2 diabetes, the prevalence was similar in males at about 26% and females 33.8%. The prevalence does increases with age and was present in 13.3% for more than 50 years of age. 40% of the subjects more than 50 years had diabetic peripheral neuropathy. So the most common form of peripheral neuropathy would be diabetic peripheral neuropathy. Now, how do you evaluate the diabetic peripheral neuropathy? The conventional testing methods have been the temperature or the pinprick sensation, which assess the small nerve fiber functions. You use the vibration sensation using a 128 hertz tuning fork for large fiber function, and you can use a 10-gram monofilament to assess the protective sensation. You also can do autonomic testing. Well, in patients or symptoms of autonomic neuropathy, one of the easier means is evaluating blood pressure in different positions, lying down, sitting, watching for postural hypotension and drop is a sign of autonomic neuropathy. Doing electromyography to measure the electrical discharge in the muscles. Monofilament testing, as mentioned, to look at the protective sensation. The nerve conduction studies, and some quantitative sensory testing. I shall take you through some of these in detail. But what is the criteria for clinical diagnosis of neuropathic pain? Well, it's continuing pain which is disproportionate to any inciting event and must report at least one symptom in 3 of the 4 following categories. Sensory symptom, it could be hyperalgesia or allodynia. The vasomotor symptoms, which could be temperature asymmetry and or skin color changes and or skin color asymmetry. Pseudomotor or presence of edema. So any edema or sweating or sweating asymmetrically in the limbs is again a sign of pseudomotor sign of neuropathy. And motor or atrophy or trophic sign, which is decreased range of motion and or motor dysfunction and or trophic changes as seen in the changes in the hair, skin, and nails. So it will require symptoms in 3 of the 4 different categories. Now, what are the common screening tools for neuropathic pain? Touch and pressure sensation screening and test for vibration loss. Test for temperature sensation. So let me go back. You can do the touch and pressure sensation screening with the same 10-gram monofilament or vibration with the 128 hertz tuning fork. You could do the temperature sensation using a conventional metallic rod, which heats up or cold, becomes cold depending on where you dip it, and do the temperature sensation testing. And then you can check for the ankle reflexes using your hammer, which is a conventional clinical bedside testing. Now, what is a sensible approach to the diagnosis of diabetic peripheral neuropathy? One is medical history, assess the symptoms, burning, shooting, or electric-like pain. Hyperalgesia, that means increased sensation. Allodynia, extremely sensitive to any kind of touch. Different paresthesias, tingling, numbness, poor balance, and falls. So those would be the history. In clinical examination, at least one test for small fiber. You could do either the pinprick or the thermal discrimination using hot and cold to see how much the patient can feel. At least one test for large fiber, which could be either a vibration sensation, light touch sensing using your 10-gram monofilament on the dorsum of the great toe, proprioception, which is holding the patient's great toe at its base and moving up and down with the patient's eyes closed to make them answer whether they are with their eyes closed, they are able to tell you whether the toe is being bent down or up. That's proprioception. And looking at for the presence of deep tendon reflexes, especially the bilateral ankle reflexes. Your differential diagnosis is important. You should consider and exclude alternative etiologies, kidney disease, thyroid dysfunction, alcohol, vitamin deficiencies like B12, and use of medications, amyloidosis, infections, and different inflammatory disease. There are innovations in diagnostic approaches. Innovative and diagnostic strategies are improving the detection and diagnosing accuracy. Well, recent advances do focus on non-invasive techniques, a lot of good point-of-care devices available, some quantitative sensory testing, and more use of AI and machine learning applications. These advancements aim to enhance the diagnostic accuracy and, more importantly, may help us in diagnosing this at the early stages before it gets advanced. Skin autofluorescence is also recognized as a diabetic neuropathy risk factor with potential screening value. These are different novel methods and biomarkers in diagnosis and evaluation of diabetic peripheral neuropathy. You have corneal confocal microscopy, which has been a non-invasive way, requires some specialist training and equipment and lack of normative data. So it's a field which is interesting and yet evolving. You have nerve excitability testing, requires again specialist training. You have microneurography, minimally invasive, may be helpful in identifying treatment responsive pain phenotypes and allowing us to use more precision medicine. This also would require specialized training, not specific to neuropathy pain, though, and again, lack of normative comparative data. The other means are neurofilament light change, use of neuroinflammatory markers, and some functional MRI as means of biomarkers for pain. Non-invasive techniques, you have there have been advancements in these methods. Techniques, as I said, such as corneal confocal microscopy and nerve excitability testing are at the forefront of this innovation. You look at corneal confocal microscopy, it's non-invasive imaging technique for detailed visualization and quantification of corneal nerve fibers to diagnose diabetic neuropathy. So just the same way we look for fundoscopy and retinal changes, these devices may help us look at the early detection of peripheral neuropathy by identifying the corneal nerve fiber damage before advanced neuropathy sets in. They provide biomarkers, which includes corneal nerve fiber density, corneal nerve fiber branch density, and the nerve fiber length, which allows one to assess neuropathic severity. And again, here, machine learning and AI will play a huge role moving ahead. Then a lot of good point-of-care devices. Point-of-care devices are devices which are referred to small in size, can be used at the clinic with immediate results. So devices like NeuroPad, Pseudoscan, and different devices available in the market, they allow objective measurements of the peripheral nerve function in primary care settings. They are more and more routinely employed for screenings in the clinics. So these are some of the examples of NeuroPad, Pseudoscan, or NC-STAT DP and check. You also have measures of quantitative sensory testing, which we tend to use more in our centers. So you have these quantitative sensory devices, again, point of care, bedside devices like NeuroTouch available in India, which helps in detecting both small or large fiber abnormalities and quantifies that in its test reports with clear indications of the stage of neuropathy and also with some guidance for how to prevent further progression. Then you have skin biopsy techniques. Minimally invasive skin biopsy have become increasingly utilized. Method is recognized for its accuracy and ability to inform treatment strategies. A skin patch biopsy is more sensitive than any other test for diagnosing the neuropathies, and it's easy to perform and almost painless. So small fiber neuropathy is for picking that up. The skin biopsy is becoming more and more accurate and a means of diagnosing that. Finally, a little small conversation on machine learning. The integration of machine learning in diagnosing DPN is transforming traditional diagnostic process. Various AI algorithms are being used to analyze the data sets, again using a lot of bedside and point-of-care devices, which based on the algorithms are able to identify the at-risk foot and presence of neuropathy and way before the patient gets symptoms, which brings them to the patient. So routine screening with use of these models is improving early detection. Moving quickly to the management part of neuropathic pain, well, we need to understand the level of risk and different interventions from most invasive interventional techniques to use of injections to oral medications, sometimes only topical medications, and of course, the psychological and physical approaches, which have a huge role again, based on the fact that a lot of pain origins from the central origin. So you start with non-pharmacological management, looking at cognitive behavioral strategies, which have a huge role to play in pain management in general. So meditation, biofeedback, and relaxation therapies. Physical rehabilitation, more and more used and recognized. Alternative therapies like acupuncture and use of TENS, which is your transcutaneous electrical nerve stimulation. drugs which target various mechanisms. So this is the larger principle to understand how different drugs work. So one is the peripheral sensitization, working at the dorsal horn, the peripheral nervous system. Your local anesthetics, topical analgesics, anticonvulsants, tricyclic antidepressants, and opioids would work largely on the dorsal horn. Then you have the central sensitization, which is going to be working again on the part of the central nervous system from the dorsal horn, which is your again anticonvulsants, opioids, tricyclics, and SNRI. And then looking at the descending modulation for the spinal nerves, the relay between the brain and the dorsal horn and through the spinal nerves, you have the role of anticonvulsants, opioids, and tricyclic antidepressants. So essentially similarly large group of drugs which would work at the level of the brain, spinal cord, and the dorsal horn, and the peripheral nervous system to give the relief. Let's look at a quick guideline. How do we go about the management of painful diabetic peripheral neuropathy? Well, risk factor and lifestyle modification extremely important. Optimize glycemic control, optimize cardiovascular risk. You're looking at monopharmacotherapy, preferential choice for gabapentinoids. You have pregabalin or gabapentin, followed by tricyclic antidepressants, amitriptyline or nortriptyline, keeping in mind the cardiac comorbidities, and then the use of serotonin, noradrenaline reuptake inhibitors like duloxetine or venlafaxine. You also have role of non-pharmacological support in treatment like the psychological measures, acupuncture, TENS, etc. Now, after you've used the monopharmacotherapy, if it's partially effective, add second treatment. If it's ineffective or intolerable, you switch to alternative monopharmacotherapy. So for those on gabapentinoids, you may consider addition of SNRIs or TCAs and so on. Or today, if you have only partial response to monotherapy, consider the use of combination pharmacotherapies as shown. The most effective pharmacotherapeutic class of drugs are gabapentinoids, tricyclic antidepressants, and the SNRIs. And then here you have the dosages mentioned for the conventional drugs. For pregabalin, 150 to 300 milligram per day, duloxetine, 60 to 120 milligram per day. And similarly, this chart here is telling us about the use of the first-line agents. For amitriptyline, 10 to 25 milligram. And then you have the optimum dosages for the second-line drugs and the class of drugs that they belong to. So pregabalin is an alpha delta 2 calcium ligand. You have duloxetine, which is an norepinephrine and serotonin reuptake inhibitor, amitriptyline and non-triptyline tricyclic antidepressants. Then again, you will have drugs in similar different categories and their dosages listed here. So again, to remind conventional guidelines, duloxetine 60 to 120 milligram per day. Some societies would recommend duloxetine as a first line. Many prefer to use this if it's accompanied by comorbid depression. Duloxetine does become a good first line drug. Or you use the ones which are again going to be more beneficial for pain relief. Venlafaxine 150 to 225 milligram per day. Gabapentin 1200 to 3600 milligram per day. Or tricyclic antidepressants 25 to 150. Use them with some caution in the elderly and those with cardiovascular comorbidities. Also, we realize the role of chronic inflammation in the DPN pathogenesis. Let's not forget hyperglycemia, dyslipidemia, insulin resistance, all of this through systemic inflammation, endoplasmic reticulum stress, oxidative stress, all would lead to activation of protein kinase C and activation of the various inflammatory markers. This increased expression of the inflammatory markers, release of macrophage and inflammatory cytokines, all of this will eventually land up causing neuronal damage. So there is a huge role of chronic inflammation secondary to insulin resistance, hyperglycemia, and metabolic insufficiency, which probably also gives us an avenue to think of molecular pathophysiology to be targeted. So you're looking today at drugs which may work as antioxidants or reducing or protein kinase C inhibitors as a potential for treatment of diabetic neuropathy. Moving ahead, in some more innovative and recent treatment, various innovative therapies have been looked at because not only it's not always possible that the drugs are getting great response. So you're looking at combined endurance and sensory motor training, help improve the patient's balance, especially for those with more predominantly motor neuropathies, enhance peripheral nerve conduction velocity, boosting glycemic control, and of course, a huge role of improving the lifestyle for the patient. Pharmacological innovations, exploring agents for patient reduction, topical capsaicin cream, alpha-lipoic acids, acetyl L-carnitine. You have some emerging drug classes, M-opioids, and some new drugs in the SNRI group of medications. You have a list of different drugs like alpha-lipoic acid, benfotiamine, vitamin D, epalristat, which is an aldose reductase inhibitor, SNRI, opioids, oxacarbazine, and many. And in the interest of time, I'm not taking you through the details, but what is their status in terms of approval, what the studies have shown, is all mentioned in this particular slide. You also have bioelectronic therapies. And let me summarize by saying that bioelectronic therapies were explored in small cohorts of patients with painful diabetic neuropathy. The TENS in a retrospective study showed that an average use of 1.7 years with 76% of patients reporting subjective improvement in pain. So for persistent, unresponsive neuropathies to the drugs, you start considering bioelectronic therapies. This is how bioelectronic medicine actually works, through stimulation of the nerves and giving patients the pain relief. TENS therapy efficacious as novel treatment for diabetic peripheral neuropathy. This article was published in DRCP and urges us to consider this as an effective and safe strategy. Diabetic polyneuropathy, advances in diagnosis and intervention stages. Again, a wonderful article in 2016 systematic review which said alpha-lipoic acid, opioids, botulinum toxin, Mexidol, reflexology, and Thai foot massage had significant beneficial effects on diabetic peripheral neuropathy of the feet. Moving on quickly to look at the efficacy and safety of mirogabalin in patients with diabetic peripheral neuropathy, a systematic review and meta-analysis, which concluded that mirogabalin, in the same group of those gabapentoid drugs, is efficacious as novel treatment for neuropathic pain. It was superior to placebo and pregabalin in decreasing the pain scores over time. Besides, mirogabalin was largely safe and associated with some adverse events that could be managed conservatively. And you're looking at different, this is an article by our friends Ashu Rastogi and Edwin Jude, which concluded a novel MONRI group of drugs to which mirogabalin belongs. SNRI and carbaminoid receptor agonists have shown some promise for neuropathic pain. Let me finally conclude by saying that in conventional means, current medicine has been that one treatment fits all, that we start using the same drugs, we try gabapentin for everyone and then move to other group of drugs. But as we move ahead, it's going to be more personalized diagnostics. So you have some means being devised, which would tell us that even for neuropathic pain, which kind of drug, whether the patient is likely to respond to an SNRI more, to an opioid more, to a gabapentinoid more. So we are able to offer more personalized treatment on the basis of personalized diagnostics as we move ahead in future medicine. Future directions in personalized treatment: identify metabolic risk factors, develop personalized treatment approaches based on individual characteristics, emphasize the need for disease-modifying treatments, and research continues to explore underlying disease different mechanisms. Let me conclude. Innovative diagnostic strategies for diabetic neuropathy focus on improving early detection and its accuracy. Increased prevalence of diabetic neuropathy proves that the approved drugs for neuropathic pain have limited efficacy. So one, we should optimize the drug use. Very often we use minimal strength of the dose and then we keep changing. So do increase the dose as long as the patient can tolerate that to give the right chance and efficacy. The evolving novel therapies focus on a better understanding of the pathogenesis, even at molecular level, and may unravel newer treatment targets with better pharmacotherapeutic agents in the future. With that, I thank you all. And once again, thank you for having me here in this wonderful session. Thank you, DFoot International, especially the Southeast Asian region.
for this detailed presentation, Dr. Manoj. Now we will have Dr. Amit Naghate, who will be speaking on how the foot is offloaded in India. He's a very young, dynamic physician from Aurangabad, where DFSI was organized in 2013. Dr. Abbas would remember. Dr. Amit, I think we can see his video.
Good morning, all. I am Dr. Amit Naghate, diabetologist and a diabetic foot care expert, practicing in Aurangabad, city of Aurangabad, Maharashtra, India. Today, I am discussing the topic of offloading. As we all know, diabetes mellitus affects our legs in two ways, majorly by formation of end glycation end products, which leads to neuropathy, vasculopathy. Neuropathy, we have got motor, sensory, and autonomic neuropathy, which leads to lots of protective sensations, deformity formation, high pressure points, callosity formation. The autonomic neuropathy leads to dryness of skin, which leads to cracks, and sometimes within the cracks there might be the bacteria goes in and the infection formation happens. This neuropathy can turns on and affect us our foot in form of Charcot foot orthopathy, whereas vascular acts in two ways, or microvascular angiopathy and a macrovascular angiopathy, where we have got structural abnormalities with AV shunting in macrovascular angiopathy. And the macrovascular angiopathy, we have vascular occlusion leading to ischemia and gangrene of the foot. Risk factor for ulcer formation in general and systemic contribution because of uncontrolled diabetes, duration of diabetes, peripheral vascular disease, blurred vision, chronic renal disease, old ages, whereas local factors affects majorly because of peripheral neuropathy, structural deformities, trauma, callus, the previous history of ulceration, prolonged elevated pressures, and limited joint mobility. How does foot injury occur in a diabetic patient? It's majorly because of pressure. Pressure is equal to force divided by the area. The body exerts two type of force: a normal perpendicular force, body surface on the force, and a shear force which is tangent to the body surface. A smaller contact area is equal to higher pressure point. Just like our metatarsal heads, which are rounded in shape, once that rounded body or a rounded object comes in contact with a flatter surface area, there is higher pressure point in between the two contact areas. Hence, there is ulcer formation or a skin breakdown can happen. Skin breakdown usually happens between 500 to 700 kilopascals. Once we reduce the pressure below the 500 kilopascal, then the healing starts in. Deformities can cause more elevation of pressure, and callosity in turn itself raise pressure by 30 times as per the nomenclature. Here there is a callosity increases the pressure, which I told you, by 30%. The first figure on your right hand side, there is a callosity over here, just a small nick, and I'm just removing it. Then there is an ulcer formation beneath it, that is a subscalar ulcer formation. The skin breakdowns of plantar pressure exerts 600 kilopascals, because of which anoxia and ischemia occurs. The instant recovery does occur in a non-diabetic patient. Delayed recovery occurs in diabetic patient, which leads to formation of inflammation, warmth, and erythema, which leads to blister formation, and then that tends down to ulcer formation. There is a vascular phenomena where while pressure generation is 600 kilopascal, which I've already shared while walking, if we say that systolic blood pressure, once we exert 120 mm of mercury to obliterate a brachial artery, that is just 15 kilopascals. So while walking, we are having 600 kilopascals. Capillary obliterates at 6 kilopascals. So 100 times or 1,000 times the pressure increases, because of which while walking, because of which there is delayed ischemic recovery from ischemic changes, and this leads to tissue loss or tissue damage, low oxygen concentration, and more injuries would happen to the individual. So this is what I was telling about. If we say this is a rounded first metatarsal head, then there is a claw deformity which leads to pressure on the tip, and because of neuropathy, there is a high pressure area. Then this tends to, there are callosities over here, which tends to break down, and because of which ulcer formation would occur beneath it. 80% of diabetic foot ulcers are within out. Diabetic foot ulcer is a mechanical problem, and no amount of antibiotic or dressing will heal the wound unless and until we reduce the pressure. The program, which has been we are practicing since long, has given us a very important assessment of risk, high risk foots and ulcer formation. We can see here we have got red patches, red lines, blue lines, green lines. So this is what the graphical representation comes in. And what we do is we usually analyze it that there is a high pressure point over here, then the second metatarsal, and then the second toe and the first metatarsal. So here are the big pressure points elevated. Once we try and redistribute it, this pressure, then there is prevention of ulcer formation in this patients. If we see a podogram, normal foot comes down from heel, second metatarsal head, straight above. Whereas in flat foot, if we can see, the line of axis has changed down. There is a midfoot which is touching down, or pressure occurring at the midfoot. There is a pressure which is occurring at second, third, and fourth metatarsal heads in a flat foot. Whereas high arch foot, there is a highest concentration, or the pressure area which is exerted mainly on first metatarsal head and the first toe or the great toe. The prevention of excess pressure on a point that tends to ulcerate is usually referred to as offloading. It is to remove the factors that causing persistent local ischemia, which leads to ulcer formation and its persistence. Reducing the number of loading cycle, that is a walking cycle, of we reduce walking, then the pressure is not going to be there, so offloading would happen. Or redistributing the pressure by use of offloading, that is by a footwear, offloading footwears, or by surgical offloading. Methods of offloading are bed rest, crutches or walkers, total contact cast, modified footwears, rocker outsoles, outsole wedges, flares, insole stress relieving pads or wings, metatarsal bars or pads. And recently we have started using or doing surgical procedures which helps to offload the foot internally. So in foot arthrosis, mainly we have got external and internal arthrostic changes. Internally, we do arch support, heel pads, heel cuffs, metatarsal bar, metatarsal pads, and toe separators. These are some images where you can see metatarsal bar is there. There is arch bar, front offloader. There are toe separators here. There is a ring to accommodate the ulcer there. So these are various type of insoles we use to offload the foot. There are the external offloaders where we have got front offloader, we have got hind foot offloader, there is a rocker, and there are some another footwears where this is a footwear where we can accommodate the foot along with the dressing, and these are the pellets which are being removed so that to offload the foot as it is. And once we do a podogram, then we can have a insole, a modified insole, so that we can reduce the pressures and offloading can be afforded. So these are different MCR pads or soles we can directly stick to the inner surface of the footwear, and the patient, the foot can be offloaded. So if we see that the normal pressure distribution, between, this is schematical normal distribution between flat insole and a molded insole. So in flat insoles, there are peak point pressure points at metatarsal heads as well as the plantar as well. Once we have a molded or a customized insole, then the pressure is evenly redistributed. So this helps us to prevent ulcer formation and pressure molding. So this is what it is. While walking a barefoot, there is a first metatarsal head which is being touching the ground promptly, and pressure is adopted there. If we after giving a rigid rocker insole, the plantar pressure at the forefoot is during the push-off is being reduced by 30%. So these are another footwears or insoles we can directly modify and stick to the inner soles, and the foot can get offloaded. Uh, at high risk foot, just like here, where there are various deformities along with scarring, significant scarring, and this, we go for a molded insoles, and the molded insole goes into the shoe, and the foot is offloaded. There are other offloading devices where fixed ankle braces are being used. Where the foot is unstable or unstable foot, and severe neuropathy with deformities is there. There is another patellar brace where is indicated in less than one-third of the plantar surface is available for weight bearing. For example, a shorter or a 4-foot amputated foot is there, and we need to mobilize them. Then patella tendon breast orthosis can be used. So this is this is a case where 60-year female, known diabetic, came to me for with this con. This is for severe neuropathy. ABI was normal. We just simply debulking. There is a first metatarsal head which is being touching the ground promptly, and pressure is adopted there. If we after giving a rigid rocker insole, the plantar pressure at the forefoot is during the push-off is being reduced by 30%. So these are another footwears or insoles we can directly modify and stick to the inner soles, and the foot can get offloaded. At high risk foot, just like here, where there are various deformities along with scarring, significant scarring, and this, we go for a molded insoles, and the molded insole goes into the shoe, and the foot is offloaded. There are other offloading devices where fixed ankle braces are being used. Where the foot is unstable or unstable foot, and severe neuropathy with deformities is there. There is another patellar brace where is indicated in less than one-third of the plantar surface is available for weight bearing. For example, a shorter or a 4-foot amputated foot is there, and we need to mobilize them. Then patella tendon breast orthosis can be used. So this is this is a case where 60-year female, known diabetic, came to me for with this con. This is for severe neuropathy. ABI was normal. We just simply debulking of the OPD, debulking of the skin, or removing the upper layer of the tuft skin was done. This is what I mean to say. And after a month, with several routine visits, this thing got reduced, and ulcer was been reduced. We did footwear modification with metatarsal bar with a scooping in, so to accommodate the callosity or the deformity. There's another where there is ulcer over here. He underwent shown to plastic surgeon, general surgeon, underwent skin grafting 3 times, had done a punch biopsy. There was nothing found in biopsy and this. Again, the debulking of the thing was done. Offloading was offered. This where the on 42nd day, sugars where the ulcer got healed completely. This is just the simple offloading method or technique which I have shared you previously. This is what the practical demonstration with my patient I have shown to you. Now, coming down to surgical offloading techniques, where if we have a IP joint ulcer, then what we do is there is a hilus rigidus. There is a toughness of the first metatarsal head due to plantar fascia thickening and intrinsic muscle tightness. So what we do is we go for selective plantar fascia release. If you can see, this is the plantar fascia which is released over here, and if you can sorry, if you can appreciate, the first toe is going back significantly. So this is how we offload the thing surgically. Then there is another procedure called as scalars orthoplasty, where we remove the second phalanx base from the upper end for the ulcer, and it gets healed permanently. This is what the X-ray showing where the proximal excision has been taken out. Then we go for flexor tenotomy with the ulceration at the tip, where the FHL is tightened. So we go with the percutaneous with a 18 blade number needle. Just insert the needle and go in this tangent manner, and we can release the tendon, and we can achieve the healing with it. This is a cloto deformity where the Gladstone talar tendon transfer has been done. This is what I mean to say. It's flexor digitorum longus to flexor to extensor extension with the Z plasty extensor has been done. This is what the correction post-operative came down. There is another entity where TA is tightened up, or the effect of tricep cuff is more tightened up. So what we do is we go on with release of the gastrocnemius, so that the 4-foot ulcers, majorly the 4-foot ulcers, get released, and there is movement at the joint, so that the ulcer get healed up completely, and there is no recurrence of the ulcer later on. This is what the pre-operative. There is tremendous pressure over here. There is release of pressure over here. So we can appreciate the distance. There is pre-operative, it was 2.7, and post-operative it is 1.3. There is another where if we have a second metatarsal head prominence over here, leading to ulcer formation, then we did a metatarsal head excision. Because of that, ulcer didn't recur and it healed it completely. This is the X-ray where the metatarsal head is being excised. There is another way of first metatarsal head where we do Roberts-John EHL transfers. There is air force to accommodate the deformities and offloading offered. This is an individual offloading device or the footwear which has been customized for the individual patient. TCC, as we all know, and the advantages are compulsory or forced compliance is there. Shortened length stripe leads to pressure redistribution, reduces activity, so reduce plantar pressures, and this is a gold standard we all know in that way. This is what another patient where had second and fifth metatarsal head ulcers healed up in 55 days. TCC was applied with a bony window just to do daily dressings or alternate day dressings, and the healing gets achieved. As we all know that endoachilles tightening is there. Once we go for a 4-foot amputation, then the fulcrum is been reduced, because of the fulcrum going away or mismanagement of the fulcrum happens, because of which biomechanical changes occurs and there is a more pressure at the forefoot or the midfoot where the transmetatarsal amputation has been done. The pressure goes on increasing there. So we need to release the tender Achilles to manage these ulcers. So deformed foot with good footwear is preferable than amputated leg with a sophisticated processes. This is what I mean to say. Foot are there, deformed foot is there, a walkable foot. So it's more preferred. Faster the gait, higher the pressure. Longer the stripes, higher the pressure. So we need to alter the patient's what we say it as physical exercises schedules as per his deformities or pressures points and pressure studies and his neuropathical status. In patient with diabetic peripheral neuropathy, distance needs to be measured in minutes, not in kilometers. Prevention is the major goal. Protection of footwear for foot for further complications and periodic offloading and continuity in the care is to be given. IWGDF guidelines states as the first choice is non-removable knee-high device (TCC) or non-removable walker. The second choice is removable walker, high heel or ankle devices if the first is not tolerated. The third choice is therapeutic footwears with fillers or foams. Surgical offloading techniques, which I've already explained, Achilles tendons release, metatarsal head excision or resection, osteotomy, digital tenotomies, and in infection and ischemia treat as per the underlying issues, and use removable offloading device when it is safe. Do not allow your patient to leave the clinic wearing the same pair of shoe which has caused him an ulcer. Early detection protection of high pressure areas in the foot and corrective footwears or orthosis is the only strategy for preventing limb amputation in a diabetic patient. If a offloading of the affected limb is not done, then the patient will walk to its own death. Every diabetic foot is calling us, please save me, please save me, please save me. Thank you for your patience listening. Thanks a lot.
Thank you, Dr. Amit. Thank you, Dr. Amit. And we'll now have the last lecture by Dr. Mohammed Waheed, who is our Vice President of Deabetic International from Maldives. He's having fellowship in plastic and reconstructive surgery at Royal College of Surgeons, Thailand, and fellowship of wound care specialist. He is from Maldives and head of the Department of Surgery. So he's going to talk to us how to cover the diabetic foot and what is the role of plastic surgery techniques in healing diabetic foot, which is very important. Dr. Waheed.
Assalamu alaikum. A very good morning and a good afternoon for some of you. Today I'm going to share with you plastic and reconstructive surgery techniques in diabetic foot. It is my honor and pleasure to present at this platform. Thank you very much for giving me this opportunity. As we all know that diabetic foot can be defined as a disease complex that affects all the anatomic components of the foot, including skin, muscles, or bone of the foot as a result of nerve damage, poor circulation, and/or infection that is associated with diabetes mellitus. Or it can also be defined as a syndrome in which neuropathy, angiopathy, and infection result in breakdown of tissues leading to foot morbidity and possible amputation. Diabetes mellitus is a global burden. WHO estimates that 830 million people live with diabetes mellitus. Approximately 589 million of adult age group between 20 to 79 years are living with diabetes. That is International Diabetic Foot Association's estimation. The total number of people living with diabetes is going to be raised to 853 million by 2050. And it affects a lot for our countries, as our countries are low and middle income countries. It is estimated that over 4 in 5 adults, that is about 81%, will have diabetes in 2050 in low and middle income countries. So it is a huge burden. One of the most common complications of diabetes mellitus is diabetic foot. Now, diabetic foot ulcers are very risky because cellulitis is more common in diabetic patients than a normal patient. Like cellulitis can occur 10 times more in diabetes. Osteomyelitis can occur 15% more in diabetic patients. So all of this can lead to amputation. It is estimated that every 20 seconds, a part of a limb or a limb is lost due to diabetes mellitus. And 50% of the patients undergoing lower limb amputation requires second lower limb amputation within 5 years. Mortality rate is estimated after 5 years of lower limb amputation is 78%. However, 80 to 85% of lower limb amputation due to diabetes mellitus can be avoided. Now, coming to the management of diabetic foot, I always say to my colleagues and those who are working under me that management of diabetic foot ulcers should be initiated from the day the diabetes mellitus is diagnosed. That is very important. Many of the countries still do not have the strategies to screen foot in patients with diabetes. So prevention is the most important thing to save the limbs. Prevention, prevention, prevention. After that, we will go for treatment. In treatment, we have medical treatment, non-invasive treatment, and invasive treatment. Now, what is the role of plastic and reconstructive surgery? Number one, or the first role of a plastic surgeon is to prevent amputation. Avoid major amputation through limb salvage procedures, which will significantly improve quality of life of the patient. Correction of deformities. Now, by correcting the deformities, it reduces high pressure areas of the foot, making patient to walk more stable and less painful. Now, the other important thing is wound closure by using different plastic surgery techniques, either by using a graft or using a flap, incorporating well-vascularized tissues to promote healing. That is how the wound should be closed. Restoration of function. Restoring foot function, stability, and appearance will help with mobility and the patient's ability to return to daily normal activities. All of these will minimize the recurrence of further ulceration and future problems of the foot. So that is where the plastic and reconstructive surgery is required. And that is the role of plastic surgeon. Plastic reconstructive surgery management and techniques. Now, the first thing when we think about any reconstructive procedure is to achieve an adequate vascularity. It is very, very important for the patient to have a very good, or may not be very good, but at least adequate vascularity for the reconstructive surgery. That is the key point in plastic and reconstructive surgery. Now, other than that, very good or advanced wound care is also very important. That will speed up the advanced wound care will speed up the appropriate wound bed preparation for a secondary procedure. So therefore, appropriate wound bed preparation is very, very important, and appropriate dressing is important. After that, we will come to plastic and reconstructive surgery. Here I want to highlight about negative pressure therapy. Negative pressure therapy is a technique which would facilitate wound drainage, reduces the edema, and increase the blood flow to the defected area. Now, it improves the reduction of exudate, it reduces the bacterial load, and promotes tissue granulation, therefore accelerate wound healing. It may not heal completely, but it gives more opportunity for plastic surgeon or reconstructive surgeon to carry out for further procedure without delaying the wound bed preparation. So that is very important. We have very good experience with negative pressure therapy in our patients in diabetic foot care. So when we talk about plastic and reconstructive surgery, we always follow the ladder of reconstruction. So we start with simple procedures and then go for higher and more complicated procedures. So most simple procedure will be a secondary closure of the wound, but since wounds are very big and may not be able to close secondarily, then the next step is to go for skin grafting. It is a simple and effective and less complicated procedure, but foot is an area where if the patient is an ambulating patient, there will be a lot of, especially in the sole of the foot, there'll be area of weight bearing. So if these areas are affected, we may not be able to do skin grafting. So some other technique is required to close the wound, because skin grafting will bring future complications in the weight bearing area. So it is not for weight bearing area, but it is a simple, effective, and less complicated procedure which would close the wound. But it requires a very good wound bed. It requires or it needs adequate granulation tissue for the graft survival. We have key considerations for flap surgeries. It's like all patients considering for reconstruction using flap should be evaluated for the vascular status. Therefore, we recommend CT angiogram, which would give a very good view of vascular anatomy of lower extremities, revealing as atherosclerotic changes of the vessels. However, these findings may not be the same finding when we operate. Maybe CT angiogram may gives a very good vascular anatomy, but at the time of surgery, we may find that the vessels are calcified. So at that time, it would be very difficult. Therefore, it is very important before patient is taken to the surgery or before the surgery is started, we should confirm the distal vascular flow with ultrasound duplex scan. So it is recommended that there should be at least 15 to 20 centimeter per second flow for the adequate vascularity for flap surgery. Because wrong selection of donor flap can end up in a very bad complication. If vascular status is in doubt, then revascularization by angioplasty technique or by bypass surgery is required for the patient. There are many types. I mean, there are a lot of techniques to close the wounds. It should be selected adequately and appropriately. We can do local random flaps. There are many local random flaps which is done for the closure of the wounds in diabetic foot, such as rotation flap, advancement flap, transposition flap, bilobe flap, rhomboid flap, and even toe fillet flap also can be used as random flaps to cover the defect in diabetic foot. Other commonly used flaps such as local pedicle flap, such as digital artery island flap, medial plantar artery flap, which is very commonly used. Two flaps are medial plantar artery flaps and reverse flow sural artery flap. The other flaps, which is done in very higher centers, which is free flaps, requires vascular anastomosis. These flaps includes LD flaps, gracilis muscle flaps, skip flap, radial forearm flap, anterolateral thigh flap, and medial plantar artery free flap. So these are the techniques which is used in plastic surgery to close the wound. However, there are few patients, I will not say few, but because quite number of time we encounter such patients. Those patients are patients whom although there are very good arterial revascularization techniques or procedures, endovascular procedures or bypass procedures, these patients may not be suitable for such procedures. And these patients are called no option patient. So I have read in journals, I have not seen this, but I have gone through literature of this. In these no option patients, they are using venous arterialization, and according to those literature, it is effective in saving the limbs. So that's why I have mentioned this venous arterialization. Maybe we may have some very experienced doctors here who may have done this or who may have treated with patients with venous arterialization. So these are the techniques I wanted to discuss or share with you. Thank you very much. These are my references. Thank you very much.
We can ask 2 questions to Dr. Waheed, and then we can end it, sir. Is that permissible? Just a 1 minute.
I don't know whether, because the other session is already giving us the sign that we cannot go forward.
Yeah, only 1 question we'll ask him.
Okay, ask.
Dr. Waheed, I think what is the best treatment in lower income group countries that you for covering the wounds as a plastic surgeon? What would you suggest? What would you?
Thank you very much, Dr. Milling. I think the first thing is to prepare the wound bed. For preparation of wound bed, even in a lower or middle income country, I think is the best. Can cover it simply by skin graft. That would be the simplest, easiest, and more effective treatment for covering the wounds.
Thank you. And Dr. What is best treatment for any kind of neuropathy, numbness, or thing that you would have? Any combination therapy that you mostly give to your patients? That's the last question, and then we'll end.
Right. So I wish I had an answer to tell you that there's one best solution for all. It does vary, but largely using any of the gabapentinoid drugs today with either a tricyclic antidepressant or using an SNRI like duloxetine would be an ideal combination for effective pain release and the numbness. My only advice to colleagues is to optimize the use of the drugs. Very often we are afraid to use the higher strengths and we use minimal aspects of like 100 milligram or 300 milligram of gabapentin. Patient doesn't get response. We want to start looking at other options. The recommended doses are actually higher as long as patient doesn't get side effects. We must optimize for the relief use of that. And of course, using a combination of drugs today, like in other therapies, works the best for long-term relief.
Okay, I think we are going off the time. So I thank all the faculty members who have joined today from Southeast Asia, and I thank DFoot International and the very patient and very inspiring Dr. Abbas sir to allow us to extend the time, and our president Dr. Harikrishna K.R. I think we'll meet again next year. Thank you very much, sir.
Thank you. Thank you very much.
Thank you.
Thank you.